This is Carl Bruckman in the Division of Plastic Surgery at Yale University. This presentation is an overview of the chapter written on nonsyndromic craniosynostosis. In this PowerPoint, a brief historical perspective will be given, followed by epidemiology, diagnosis, and management of the major forms of nonsyndromic craniosynostosis. Abnormal skull shape has been studied for hundreds of years, with the scientific origins behind skull growth having come about in the 1700s. Sommering was one of the first to note that individual bones comprising the cranial vault grow in a pattern that is perpendicular to the said suture. When fused prematurely, abnormal skull morphology ensues. Years later, Otto and Virchow further detailed the idea of growth compensation occurring in parallel to the fused suture. It wasn't until the mid-20th century when Melvin Moss, an anatomist, questioned what was the driving force behind skull growth. His theory of the functional matrix stated that skull shape is dictated by the underlying growth of the brain causing strain on it. More extensive work was later performed in animal labs. Person in the 1970s manipulated the cranial sutures and noted how the cranial base and facial bones subsequently developed misshapen features. Persing also confirmed these findings with animal studies, as well as developed some early concepts behind the cranial vault distraction. From a cellular level, Opperman's lab provided important detail on how the dura and periosteum intricately function with sutural growth, and Drake noted that both fused and non-fused suture elements can be excised and then subsequently redevelop in the same topographic location. Epidemiologically, craniosynostosis occurs with an incidence of 1 in 2,500 live births. The sagittal suture most commonly fuses prematurely, followed by the unilateral coronal, bicoronal, metopic, and lambdoid. Numerous growth factors have been elucidated in the pathophysiology of craniosynostosis, and a brief summary is provided here. An important note when considering the mechanism behind craniosynostosis is that in nonsyndromic cases, the specific suture involved is the primary source of the pathological fusion, whereas in syndromic cases, the premature fusion is likely a disorder of mesenchymal development. Also important to mention is that nonsyndromic cases are most frequently sporadic and without other systemic pathology, whereas syndromic cases follow an autosomal dominant inheritance pattern and present with other known anomalies. When examining a child that presents with an abnormal head shape, palpating for a prematurely fused suture and fontanelle patency is necessary. One should also gain appreciation for how a certain morphological change has come about. Virchow's hypothesis for a compensatory skull growth explained this, essentially stating that when a suture fuses prematurely, the adjacent bones form a singular plate with decreased growth potential along its margins. Bone deposition occurs asymmetrically and is increased at the perimeter of the fused suture and the uninvolved bone plates. Non-fused sutures in line with the fused suture continue depositing bone symmetrically with greatest compensatory growth occurring nearest to the pathological suture. Understanding this concept should allow clinical diagnosis to be made for the vast majority of single suture cases. It should be noted that there is a role for imaging in multi-sutural cases, or if surgical planning is anticipated. From a neurocognitive perspective, it is well known that patients with single suture synostosis have a higher incidence of learning disabilities than the normal population. Within this cohort of patients, evidence has shown that delaying surgical intervention to greater than 6 months of age, as well as performing less comprehensive cranial vault remodeling, has associated with reduced IQ and increased frequency of learning disabilities. There are numerous hypothetical mechanisms as to why neurological development is affected by craniosynostosis. The main ones being global intracranial hypertension, focal brain hypoperfusion, and mechanical deformation of neuroanatomic structures. Each of these areas have been studied extensively in patients with craniosynostosis. Most recently, Persing's group has looked at functional MRI as a promising diagnostic modality for studying neurocognitive development in patients with synostosis. The definitive management for craniosynostosis is surgical release of the prematurely fused suture. Much controversy exists on not only the timing of when to intervene, but also the means by which the surgery should be performed. The literature is vast on this topic. When performed prior to 6 months of age, studies have shown dramatic not only cranial vault shape, but also skull-base morphology and facial form. The surgical technique being performed will also dictate the timing of surgery. The two main methods for suturectomy are either via an open whole vault cranioplasty or a minimally invasive endoscopic approach. Advocates of each make valid points to perform the procedure either way. The open whole vault approach offers more dramatic expansion and remodeling of the misshapen calvarium and is more useful with more deformed cranial vaults. This technique is undertaken around 4 to 6 months of age, maximizing physiologic maturity of the child for the anesthetic and surgical stress, as well as performing prior to the occurrence of increased brain growth. The endoscopic approach is typically performed at a younger age, 2 to 3 months, as it is quicker and imposes less physiologic demand on the patient intraoperatively. Upward of 1 year of postoperative helmet therapy is typically necessary. Opponents of this technique argue that the endoscopic technique, while sufficient for mildly deformed single suture forms of synostosis, is not sufficient for more complex cases. Evidence has also shown that long-term intellectual outcomes are not as great compared to whole vault cranioplasty. Similarly, distraction devices and spring-mediated approaches may be used either in single suture, mild cases, or in conjunction with more extensive surgical remodeling as an additional stage. At this point, it is prudent to discuss the more common types and patterns of nonsyndromic craniosynostosis. It's important to note that while the characteristic morphology of each type is rather uniform, the specific surgical management of each carries a fair amount of variability relative to technique employed. Sagittal synostosis presents with an overall scaphocephalic head shape, thus an elongated skull in the AP dimension, biparietal narrowing, and compensated growth that leads to bulging either anteriorly, posteriorly, or both. Many cases of sagittal synostosis can be managed with an endoscopic suturectomy when they are identified early and before significant bony deformity develops. More severe cases require whole vault cranioplasty. This diagram depicts one of the senior author's preferred techniques, involving removal of the sagittal, coronal, and lambdoid sutures. A bifrontal craniotomy is also performed. Radial barrel stave osteotomies to the frontal bone are completed to open and contour the constricted, elongated anterior portion. Posteriorly, occipital barrel staves are then performed. The biparietal width is then increased and maintained with placement of a strut graft across the mid-sagittal region. Overall, the skull will now be shortened in the AP dimension, widened biparietally, and recontoured anteriorly and posteriorly. It should be noted that methods of fixation are also quite variable in synostosis cases. Some surgeons choose resorbable suture, such as the senior author, whereas others prefer resorbable plate screws. There are also some units around the world that use wire fixation. To that end, the idea of overexpanding the cranial vault versus floating the osteotomized bone is another topic of discussion. The senior author prefers fixation with resorbable suture as well as floating the contoured bone flaps by securing them to the underlying dura, therefore not overexpanding in a fixed dimension. This allows vault expansion to be directed by the stress created by the underlying growing brain. In cases with posterior compensation, occipital and parietal craniotomies are performed to remove two separate bone flaps, both of which are recontoured and opened with radial barrel stave osteotomies. The resultant bone gap is then closed by shortening of the midline sagittal strut, with subsequent replacement of the newly contoured occipital bone segments. This effectively shortens and reshapes the posterior elongated and constricted occipital aspect of the cranial vault. Unicoronal synostosis has numerous diagnostic features, including ridging and fusion of the unilateral coronal suture with ipsilateral frontoparietal flattening, retrusion and canting of the orbital vertical axis, as well as deviation of the nasal radix and temporal bulging. The ipsilateral ear is also anteriorly displaced. Contralaterally, there is bulging of the frontoparietal region from compensated growth. Radiographically, Harlequin sign can be noted due to elevation of the ipsilateral greater and lesser sphenoid wings. Surgical management is aimed at reshaping and anteriorly advancing the ipsilateral frontoorbital region, as well as recontouring the frontal bone. This is performed by creating a bifrontal craniotomy to remove and reshape it with radial barial stave osteotomies and a Tessier bone bender. Burials are also performed in the ipsilateral parietal bone. The frontoorbital bandeau is then osteotomized. It is important to note that some surgeons will remove the entire bandeau and reshape it ex vivo. The senior author prefers to maintain the bandeau at its nasofrontal and zygomatical-frontal sutures, thus green stick fracturing and tilting it anteriorly. This tilt method maintains sutural growth at the aforementioned sites. Rather than securing the bandeau rigidly, the side or sides that are anteriorly advanced are then prevented from relapsing by use of a custom resorbable plate. This plate has a U-shaped configuration at one end to rest on the basal bone laterally, and then secures to the bandeau anteriorly. The ipsilateral orbital aperture is recontoured for symmetrizing purposes, and an onlay block graft, often from split calvarium or posteriorly directed bicortical bone, is then secured to the retruded and displaced ipsilateral frontoorbital region. After this, the aforementioned tilt procedure is performed to the bandeau, with ipsilateral side being differentially advanced anteriorly. The custom U-shaped plate is placed, and the contoured frontal bone flap is secured to the underlying dura and the adjacent basal bone with resorbable suture. Bicoronal craniosynostosis is characterized by pterobrachycephaly, which means the cranial vault is increased vertically, broadened biparietally, and shortened in AP dimension. There is also retrusion of the and flattening of the supraorbital region, with frontal bossing noted from compensated growth. Ridging of the prematurely fused bilateral coronal suture is also evident. Radiographically, you can appreciate bilateral harlequin deformity and narrowing of the anterior cranial fossa. Surgical management for bicoronal synostosis is aimed at shortening the vertical height of the cranial vault, lengthening the posterior aspect, and advancing frontal orbital bandeau. There are many ways to accomplish this. The senior author demonstrates a way performing whole vault remodeling in a single stage. Osteotomies are performed to remove bifrontal and bioccipital bone flaps, leaving behind bone struts in the midline, sagittal, and coronal dimensions. These struts are then shortened symmetrically and resecured with resorbable suture to decrease the vertical height of the cranial vault. Barrel stave osteotomies are performed radially in the 4 separate bone flaps that were removed, as well as in the basal bone of the temporoparietal and occipital regions. The frontoorbital bandeau is osteotomized and tilted on the nasofrontal and zygomatical frontal sutures, maintains anterior projection with custom U-shaped plates. The bone flaps are then replaced and secured to the underlying dura and adjacent basal bone struts with resorbable suture. In the two-stage approach, which is frequently used by many, the first stage consists of posterior cranial vault distraction osteogenesis at an earlier age, approximately 4 to 6 months. This is performed via posterior skull craniotomy extended just anterior to the cranial vertex and posteriorly to a point just above the foramen magnum. 2 to 3 distractors are then secured to the bone flap and basal bone and directed in a vector that will allow posterior and inferior distraction. The distraction is then completed after a latency of 1 to 2 days at a rate of 1 millimeter per day in a period of consolidation that is approximately twice the period of distraction. The overall length of distraction is dictated by the significance of the defect. Upwards of 3 to 4 centimeters can be achieved. The arms of the distraction devices can be removed at bedside, thus allowing for the soft tissue to close over the underlying foot plates during the consolidation phase. The second stage involves removal of the distraction devices and frontoorbital advancement with contouring of the frontal bone, similar to how it is performed for metopic and unicoronal cases. It should be noted that depending on the surgeon, these two stages are sometimes swapped, thus performing posterior vault distraction as a second stage after the frontoorbital advancement and frontal remodeling are done as the first stage. Metopic craniosynostosis is characterized by a trigonocephalic head shape. This is a necessity as ridging and fusion of the metopic suture may occur physiologically at an early age. True synostosis demonstrates bifrontal retrusion, bizygomatic narrowing, hypotelorism, anterior displacement of the coronal sutures, and supraorbital flattening. The treatment for metopic craniosynostosis focuses on reshaping and expanding the frontoorbital bandeau, as well as contouring of the frontal bone. A bifrontal craniotomy is performed with removal in radial burial staves osteotomies. The frontoorbital bandeau is osteotomized. If there is significant hypotelorism, the bandeau can be osteotomized at the metopic suture, and an interpositional bone graft can be secured to widen the intercanal distance. Laterally, the bandeau is then flared anteriorly, advanced with or without the use of the tilt procedure, and secured in place. The reshaped frontal bone is secured to the adjacent basal bone and floated on the underlying dura. Lambdoid craniosynostosis is the most uncommonly seen form of premature fusion. It can occur either uni or bilaterally, thus leading to an asymmetric or symmetric misshapen occipital region. In cases of unilateral fusion, the ipsilateral occipital region is flattened with contralateral parietal and mastoid bulging. The ipsilateral ear is displaced anteriorly. With bilateral lambdoid fusion, there is bilateral occipital flattening, frontal bulging, and an elevated cranial vertex. Surgical management of lambdoid synostosis is altered on a case-by-case basis. The aim of the procedure is contouring of the posterior skull by way of biparietal occipital craniotomy, with removal of the bone flap and radial burial stave osteotomies. The basal occipital bone is also osteotomized with burial staves, and the bone flap is replaced and secured to the underlying dura and adjacent basal bone with a resorbable suture. Generally speaking, craniosynostosis reconstruction has become a procedure with relatively low morbidity. The main complications that do occur are a product of blood loss and can be largely avoided by achieving hemostasis as the procedure progresses, as well as prophylactically administering hemostatic agents such as preoperative erythropoietin, tranexamic acid, and blood transfusion. Air embolism is also a known complication, albeit rather uncommon. This too is a function of blood loss in low volume reserve, as air is incorporated into the vascular system after osteotomy are made. Increasing the circulating blood volume preoperatively and maintaining it interoperatively is helpful. Placing bone wax over the diploic spaces once osteotomies are performed and the use of a transthoracic Doppler ultrasound also reduce the risk of this complication. Infection can also occur and is best prevented by providing perioperative antibiotics and maintaining sterility intraoperatively. Overall, the diagnosis and management of craniosynostosis has evolved over the years and continues to do so. Although the treatment is rather standardized, an individualized approach to each deformity is necessary for the patient. and, as alluded to previously, open whole vault cranioplasty is advocated by the senior author in order to fully release the fused sutures, maximize intracranial volume expansion for subsequent brain growth, and remodeling misshapen cranial vault aesthetic improvement. Thank you.